Responder rehab is a new protocol that will appear in your 2012 protocols for the Hennepin County ALS protocols, and I've waited till now till those protocols are finalized to present the information. Some of the fire departments have already been exposed to this information for a number of months, but we needed to wait until we knew exactly what the EMS portion was going to be. So I want to talk to you about this process of rehab, what the goals are, what the objectives are, kind of how it came to be, and then what our role is, how it all fits together. So I've given you some handouts already. Those are nice to know information. It's not need to know information. Your need to know will be in your 2012 protocols. We're going to talk about the history of NFPA, kind of the scope of what 1584 covers, and then how this rehab process is intended to work. So in the fire service, there's a program called Everyone Goes Home, and we use this with their permission, and the purpose is to draw attention to the number of line of duty deaths that occur within the fire discipline every year, and many of those are preventable, and rehab becomes one of those. And in the process of developing this protocol, we interviewed a lot of different agencies, fire agencies, and I asked them, do you have protocols on rehab? Is it compliant with 1584? And in many cases the answer was yes, we do have protocols. Great. What's the triggers? When do you activate that? How does that happen? And invariably the answer was, well, when we have the big one. Well, when's that? I don't know, I'll let you know. So while they maybe had protocols for rehab, they weren't actively using them, is what tended to be the case in many areas. So the history on this thing is, in 2003, NFPA put out a recommendation. It was numbered 1583. And it was a recommendation on rehab and the rehab process. Unfortunately, as a recommendation, it only got a lukewarm response. A lot of fire discipline, a lot of fire agencies looked at it and said, okay, got it, now we go back to business as usual. And they didn't make any effective changes. So the protocol was revised, it was republished in 2008, and it's now numbered 1584, and it is a standard, meaning it's a mandate for those who subscribe to follow the rules of NFPA. What's important is even if you don't subscribe to follow the rules of NFPA, you need to recognize it's still the standard. It's what you more than likely will get measured against, which is especially important for different fire agencies. So what we sought to do was establish a standard set of protocols. Our awareness about firefighter rehab and about responder rehab, and let me just make a side note that we built this around the fire service because of the high level of exertion that firefighters go through when actively working a fire, and in heavy turnout gear, in extreme heat conditions and so forth. But the intent is that this policy and this process applies to all responders, not just firefighters. It came to our awareness about a year and a half or so ago when Massimo was starting to sell their RAD 57, the CO detection device. And to get people in the door, they sponsored some national speakers, people who were well versed in the national standard of 1584. And that's what really got our attention, and that's how they got people in. And we started to talk and realized that, fire departments are heavily engaged in mutual aid responses, particularly suburban and paid on call and volunteer services. And so those departments really needed to have a common framework of how they were going to do this. And the same is true for EMS. Any number of EMS agencies could be called to support a fire operation. So it really would behoove us to have a framework that sets a single set of expectations for all of us. And that's what we sought to do. So we put out a call really across the state of people interested in discussing this issue and seeing what we could come up with. And this is the list of participants that helped develop this particular protocol. And of note is that we've got full-time urban services on there. There are suburban paid on-call services. There are rural volunteer services on there. And just talking about the fire discipline. And you've got a variety of EMS services. So everybody got to put their concerns and their issues and their operational parameters on the table so that we could consider all of it and design a framework that would be flexible and adaptable regardless of the type of service or operation that is involved. For example, You look at Lake Elmo over here. Lake Elmo Fire is not a big department. They're a volunteer department. They are strapped for personnel even on a good day. And so their first reaction was, ooh, rehab. I got no one to do that. Hey, great, EMS, you do this. And EMS is going, no, we can't show up at all your fire calls just to do your rehab process. You need to own part of that, and we will come in and we will support our part of it. It needs to be a partnership. So that's what developed from this. So NFPA, you'll see, applies to just about every kind of operation you can imagine. And preceding this, you were most likely to see rehab involved in hazmat responses. Those guys have to have medical evaluations before they get into level A suits and after they get out of level A suits. But for a lot of the other stuff, rehab just didn't happen. Not well, and certainly not in a formal manner. And that's not to say that rehab has to be formal. It can be very informal. I'll talk about that in a minute. And you'll see that emergency medical services up here, and that's really addressing more of the fire-based EMS. But fire-based or not, if you're third service, if you're hospital-based, if you're private, you still have an important role to help complete this whole rehab process. So we developed a statement of purpose, and really this was intended to define some boundaries, what we were going to do and what we were not going to do. And the first bullet is that it's a collaborative effort. This wasn't anybody working in a vacuum to develop this. So understand a lot of input went into this from a lot of different angles and perspectives. The second thing is its purpose is to have a proactive process to protect all responders, firefighters in particular. Thirdly, this addresses that we recognize there's a lot of variables, and this is just a framework that we can all work with. The exact tactics and processes that each agency employs is up to those agencies and what equipment that they carry and what services are available to them and so forth. But it can all fit within this framework and allow for a seamless integration between different fire agencies and different EMS agencies. And lastly, some boilerplate language, particularly for fire agencies, that this isn't intended to replace anybody's existing policy, but perhaps augment what they already have in place. So this idea of line of duty deaths is what's driving this. And this data sources from 2006, but this particular year, which might be 2005, there was 114 line of duty deaths for firefighters nationwide. That's a pretty significant number. And understand that line of duty deaths are not just happening on the fire ground. It could in many cases be the case where they worked the fire, they packed up, firefighter goes home, he's not feeling well, he lays down on the couch, the blood pools, he throws a clot, has a massive heart attack or stroke. So look at the first line here, heart attack, 39% for career, 50% for volunteer. That's the leading cause of line of duty death for firefighters. Not falling through basement floors or falling through a roof that burned through. It's not crashing vehicles. It's not asphyxiation and other traumatic injuries. It's heart attack. And look down at the bottom. The number one cause of the heart attack, stress and overexertion, 97 and 98%. That's something that we can impact positively. And that's what's driving this whole initiative. I'm going to make a comment. If you look at more current data, for example, the data for 2011 shows the total number of line of duty deaths are in the low to mid 80s. So it's a drop from this 114. But what they dropped were these trauma-related and asphyxiation-related causes. They got better at some of those safety procedures, and what that did, it drove the percentage for heart attack up. So if you look at the current data, it'll say heart attack and stroke, both are included now, and it pushes this up in the high 60s up to near 70% for the cause of line of duty death. So that's what's driving this whole thing. The scope of NFPA is really to cover any time we're working. It could be fire suppression, it could be training, it could be a scheduled event like a parade, it could be a non-fire activity where perhaps fire is called in to support a SWAT operation for law enforcement. But anytime we're working and we need to protect those firefighters from either exertion or weather extremes, that's what the scope of NFPA 1584 is. It covers all of it. So what I want to talk to you about is this rehab process, and we're going to talk about it in a very formal perspective so you understand what a formal rehab operation is intended to look like. But you also need to bear in mind that rehab can be very informal. And for example, one engine company may get called out to put out a car fire. Could be a reasonably easy call for them. 3 guys, maybe 4 on the engine, they put out the car fire. Do they need a formal rehab? No, but they still need rehab. And what that looks like is the guys sitting on the back of the truck, opening up their coats, cool down, and drink some water. Seems kind of benign, but that really is rehab, and we need to think of it that way to understand that we're protecting these responders by rehydrating and taking care of the body. So at the beginning of this process, following ICS, Fire Command or the IC needs to assign somebody to be in charge of rehab. That's going to be the rehab officer, and they've got some roles and responsibilities. We've designed this thing to be very, very simple, so theoretically, it could be assigned to a junior firefighter, somebody relatively new to the discipline. That's unlikely. In most cases, they're going to assign an officer of some sort, but we put it in place to cover all aspects. They get a green job action sheet that looks like this. And it's bright green, it's laminated, it's a checklist of some stuff that they need and what they need to do. And really what they're going to do is they're going to look for a rehab area. And the first thing they're going to try to find is a rehab area that allows people to sit, relax, let their vitals come down, their heart rate come down, they drink some water, but not be able to watch the incident. If you're still watching the incident, you're going to stay mentally engaged, and it's harder to let your body come back to a relaxed state. They're also going to look for an area that's uphill or upwind. We don't want smoke and other toxins blowing into the area. We need to have good ingress and egress for EMS so they're able to support the operation. They're going to need some stuff like food and water. You might need protection from the elements, whether that's protection from extreme heat or extreme cold. Area also has to have a good inflow and outflow, a place where they can swap out their PPE. So what that looks like is this diagram. Down at the bottom there's a cascade truck or an air supply truck where they can swap out bottles. We've got a changing area. If you look right up here, this is an accountability area where they need to log in and log out. They want to track that crews are going through rehab, show that they were being protected. Here's a rest area, and in this area they'll go through what's called medical monitoring. Medical monitoring is an NFPA term, and that involves the initial medical assessment that is done by other firefighters. This is not an EMS portion yet. Medical monitoring falls in the fire purview. So they get a quick assessment, they get a rest area, some food and water, and it can easily transition to the EMS or medical evaluation area. Medical evaluation and be transported if necessary, or at least be evaluated further by EMS personnel. And medical evaluation, medical monitoring, those are both NFPA terms. I don't particularly like them. They're confusing, but understand what they are. And if you equate the evaluation with EMS, it'll be easier to keep that straight. So what happens in the case of a fire is firefighters will go through work cycles, and a work cycle is simply defined by the amount of time it takes for them to go through one tank of air. And for some cities that's going to be a 30-minute tank, for some it's going to be a 45-minute tank. After they've used their first 2 tanks of air, then they're going to be assigned to go to rehab. At that point they're going to come in, they're going to get checked by fire personnel. If they pass that first assessment, we want them to sit down, we want them to cool down, and that's usually the case. They're usually overheating rather than being too cold. Open up their jackets, we want them to start rehydrating and just relax for a minimum of 10 minutes. At the end of that time frame, they get reassessed the same way as when they came in, and we'll go through those questions in a minute. And if they pass, if they're cleared, then they're returned to a duty status and they can go for another work cycle. Quick note about hydration. We talk about rehydrating. Many services are now putting water in the cabs of all their trucks. And firefighters are being encouraged to drink a bottle of water on their way to the calls. So they're really doing pre-hydration. And we all know that that is far more effective than rehydration because it's easy to get dehydrated and it can be very difficult to play catch up if you get overly dehydrated. So step one, they come in, there's an assessment. We're going to talk about that. Step two, they rehydrate. Step three, we assess, and they either get cleared or they're going to have to repeat this rehab process. So the questions that they get asked are right here, and that's on one of your handouts. The key that drives a lot of this is going to be heart rate. They're not going to be concerned with respiratory rates. They're not concerned with blood pressures. That becomes very time consuming, and it doesn't serve the overall operation well. But we can determine very quickly what their condition is by their heart rate. And the threshold is their heart rate has to be 220 minus their age or less. 220 minus your age is a maximum heart rate that you should ever experience, even for those of us who are doing regular physical activity and exercise routines. If you're doing a cardiac workout, that's your peak cardiac heart rate threshold. The exception might be some Olympic athletes, but that's up there for most of us. And if you exceed that, I'll tell you from experience, you will not feel well. That can be pretty scary when you get up that high. CO, if you have a RAD 57 available, we'll certainly check their CO. What we've learned through some studies through Edina Fire is that typically you're not going to run into CO issues with firefighters while they're actively fighting fire or they're doing fire suppression. They're very disciplined about keeping their masks on and being protected through that process. The exception might be some chronic smokers. But more often than not, if CO is going to become an issue, it typically will happen during the overhaul process. When the air seems to be cleared and it's not smoking anymore, they may start removing their masks and actually inhaling some CO that's remnant. If you're going to see it, that's the more likely time is during overhaul. They get asked questions, do you have chest pain? Do you have shortness of breath? Are you nauseated? Are you dizzy? Are they mentating correctly? Are they walking correctly? So some general checks to make sure that they're hydrated and they're not having any other trouble. If they answer yes to any of those questions, and those questions were specifically designed that way to make it simple and consistent, a yes at any point means this patient needs, or this firefighter or responder needs to be evaluated by EMS. It falls outside those safe parameters. Assuming they pass, they get a minimum of 10 minutes. The advantage of this is that in many cases in the fire service, there's a strong commitment to the team. And if 3 of the 4 guys on a company are ready to go back and go back to work, the 4th guy who might not be feeling well, he's not apt to say so. He doesn't want to let his team down, and he's probably going to go in when he shouldn't, when he's not healthy enough to go back to a duty status. They get to kind of stand behind this as a protective measure. And when we did our testing of this system, it worked very well. They got used to, oh, boss says I have to wait for 10 minutes. And they would do that, and they would give their body a chance to recover. And that's the point of this whole thing. This is about recovery. That we're not trying to get them to a normal set of vital signs. We're not trying to get their heart rate below 100. They're going under a lot of physical exertion. They're going to have elevated blood pressure. They're going to have an elevated heart rate. That is normal. But what we're looking for is that their body is recovering, that when they're in a state of rest, that heart rate is starting to decrease and that blood pressure is starting to come down and so forth. They get asked the same set of questions before they go, and the key here is their heart rate has to be 110 or less to get cleared back to duty status. Depending upon how hard they're working, they maybe need a second 10 minutes. They could be there 15 or 20 minutes to get down that rate. But in most cases, it works very, very well. These guys will recover enough to get returned to duty status. And the concern, understandably, for the fire department is, I can't have all the firefighters tied up in rehab and no one left to work the fire or whatever the incident is. So we were looking for that balance. This 110 heart rate, how we got there was by reviewing a whole bunch of data from Minneapolis Fire. Through their various cadet programs, they documented, whenever they do live fire training, they document the temperature and humidity for that day, how long they were in the live fire, the burn tower. They check all of their vital signs at 1 minute, 5 minute, 10 minute, 15 minute intervals, and we had several years worth of data to review and watch how these guys would progress and watch how fast they would recover. In addition to that, there was some national data that was reviewed. And Dr. Kevin Saprell, who's the medical director for Ridgeview Ambulance, helped us with that process. Ultimately, where they landed and where the medical directors agreed is safe is 110. If we can get down to 110 or less, we know that it's a healthy recovery point. They're good to go back in. They don't have primary medical issues. That's not the cause, unlike the other EMS calls that we typically respond to. So the sheet that they look at is literally bright yellow. Again, it's laminated. All those questions that you just saw, and on the back of it we have an age calculator so that it's very easy to say, okay, who's the oldest guy in the department? Well, John's the oldest firefighter. He's 59, and his max heart rate is 161. If everyone's 161 or less, we know that they're good. They pass. We can process them through, let them relax, rest, get some fluids, and cool down. Documentation in the fire process, in the fire discipline, is an interesting animal, and it's different than what we know in EMS, and it took us a while to understand this. From an EMS perspective, when we're wearing our EMS hat, we're thinking, all right, this firefighter has been in rehab for 10 or 20 minutes. They've checked his pulse several times, and now he's not healthy enough. They want us to assess him. Well, what were those heart rates? I'd like to know. We're not going to know. In the fire discipline, anything that they document has to be included in their INFRS reporting. That's national level reporting. So they're not real interested in documenting specifics on each firefighter. In addition to that, it is extremely time consuming. So what they want to do is track to show that these different fire companies have gone through the rehab process. So they have a very simple sheet that will show the department. This might be like Richfield, Engine 1, 3 on the crew, what time in and what time out. That's all they're documenting. And I share that just so we have realistic and common set of expectations of what you will get if a firefighter needs to be evaluated by EMS. So now let's get to the EMS portion. That's what this rehab process is, and everything that we've talked about so far is really the responsibility of the fire department to manage. Like I said, Dr. Kevin Saprell is a medical director for Ridgeview. He's also a 20-plus year firefighter and really brought a unique perspective in understanding both sides of the arguments that were there. These protocols have been added to the 2012 version of the Hennepin ALS protocols, and you'll see those in about May to review. But really, this is designed to allow us to sit for an extended period of time with a firefighter who's getting better, but maybe not as quick as we'd like. We don't need to immediately put them in the truck and transport them unless they've got some other complaints or conditions going on. So what this looks like for EMS is we get called for a fire standby. We're going to arrive at the scene. You will establish EMS command like you always have. The EMS commander will make contact with fire command. And the initial phase of our standby is for any victims that might be found in the fire and any firefighters who may get injured. That's all business as usual for us. As this incident progresses, as it becomes prolonged or it grows and it goes multiple alarms, we have more firefighters getting involved. And particularly when they complete their primary and secondary surveys, their searches, and there's no victims left, then we need to start thinking about supporting their rehab process. And as EMS commanders, you need to consider, do I need to call in another truck to help support that process? You may need more EMS resources. Those additional resources, you're going to probably want at least one to be somewhere near this rehab area once that becomes established. If a firefighter gets sent to you, you're going to do a typical assessment. You're going to be asking the same questions about chest pain, short of breath, medical history, are you dizzy, are you nauseous? Those typical symptoms that you would kind of expect from dehydration and overexertion. Really need to think about doing a 12-lead EKG on these guys. If you have a CO monitor, you can do that. Check their blood glucose. And if you're concerned about CO, you treat them, period. You don't wait and base that decision on a CO monitor, a RAD-57. If this firefighter presents to you and their heart rate is more than 220 minus the age, if they're that tachycardic, you need to follow your tachycardic protocols. That's an immediate transport. That's a medical concern. We're not going to sit around and see if these people recover. If they have the other complaints of chest pain, you would treat them again following your normal EMS protocols. Traumatic injuries, the same thing. If not, it may be they just need some more time to recover and we want to check them. Now what's interesting is we tested this during some live fire training down in Edina. They've got a burn tower right off 169 and several of the suburban departments were out there. And during this process of testing, we figured out how to streamline this process, how to work through the documentation issues. But what we found, we had a couple firefighters who did not pass the assessments that we just went through. Their heart rate would not get down to 110. They were sent to EMS. They were found to have EKG changes and ultimately ended up at the hospital. That was a big wake-up call for a lot of fire departments that the process works. If somebody is not recovering, if their heart rate is not coming down, now there's probably another reason. Was it that they were out drinking the night before? They started a little dehydrated, maybe had a few extra? Possibly. It could be a primary cardiac issue, and those are the things that we're trying to catch. So, if they've got any of the symptoms, chest pain, short of breath, dizziness, their heart rate is far too tachycardic, they got their low blood pressure, we need to treat those immediately following your normal protocols just as you would. If not, then you should feel comfortable sitting on them on scene, allow them to continue to cool down, continue to hydrate orally, and see if they don't get down to a place where now they're recovered. It just took them a little extra long today, whether it's heat or they're just not feeling 100%. And as long as they're asymptomatic, they're complaint-free, there's no compelling need to transport these people. What's the only other protocol that allows you to treat and not transport? Diabetic, right? Those patients we treat and we don't transport, and we don't consider that an AMA or against medical advice situation. This is another caveat to that. This is like the diabetic protocol. It's different that way. Now, let me clarify. The firefighter or responder is asymptomatic. Their heart rate is now down to 110 or less. They don't want to be transported. You don't feel there's a medical need to transport them. You're comfortable with their medical status at this point. It's still possible the chief of that department, because of department policy or city liability or work comp issues, they may still request that we transport to the hospital. And by all means, we will do that. We'll call another truck in code 2 and we will transport them if that's what needs to happen. So understand that there may be a request of that nature coming from the department that we need to oblige. The other piece to this is that even though they may pass the static protocol, they pass this may return to work criteria. So their heart rate is down where it needs to be, they don't have chest pain, shortness of breath, or nausea, dizziness, etc., etc. But if there's something else going on that's not captured here, again, those fire departments rely and trust in your medical expertise. If there's a compelling reason, then you communicate that to the fire rehab officer. Say, you know what, I'm just not comfortable returning this guy to work. There's something else going on here. I'm not able to pinpoint it. And he probably should be transported and be evaluated by a physician. We can come up with what ifs all day, but understand that you have that latitude. And our goal is to protect these firefighters. So a quick flow chart, again, they're going to enter the rehab area, they're going to get assessed by firefighters. If they pass that assessment, we rehydrate, get them to cool down. Big note on getting them to cool down, get the jacket open, and on warm days, get them to get their bunker pants down to their knees. Because there's a lot of heat that gets trapped in that turnout gear. Get them to cool down, they get reassessed. If they pass, they're returned to work. If at anywhere along this line they don't pass or they start to feel sick or have other symptoms, they get turfed to EMS, and then we will do a more thorough evaluation of those responders. So I end this talk with the slide that says opportunities. And what I described is a very black and white process about these are firefighter responsibilities and these are EMS responsibilities. But 365 days a year, fire departments support EMS on EMS calls. They're there backing us up, helping us out with all sorts of situations. We don't get a whole lot of opportunities to pay it forward. And while we might not have a black and white need to be looking at all these firefighters, it's the expectation of this department that you will be out there. The simple things like cracking open the bottle of water when the firefighter, he's cold or his hands are wet, he might be shaky because he's tired, cranking the top off that bottle of water, getting them a cold towel to cool them down, helping them slide the pack off their back. Those little things mean a lot and show that you're watching out for their back and making sure that they're healthy. Does that make sense? Like I said, different departments have different cultures, and they're going to implement this in more aggressively or less aggressively. But the framework remains the same, and our role remains the same to help protect these guys from other situations.